Okay, join the meeting with Google.
Yeah, and then just plug in your, if you're already logged in,
Okay.
go right through, which is what it did for me.
Please confirm data. Okay, maybe I'll try it this way. Never had to do this before. Thank you.
Yeah, I know, me either. So
I had to put in my Zoom
Different tries.
password and then it worked.
Okay, let me see. I think.
but it worked.
Giving everybody a little longer to get on.
Don't worry, I got plenty of vino here.
Isabel's having a hard time. Hopefully.
Oh, it says maybe
Yeah,
now it's going to let me in.
Isabel, did you get in?
I did. I had to, it said kept joining meeting and then it asked me to sign in. And then finally I just went the Google route and it
Okay.
did it that way.
All right.
Yeah, let me join it.
All right. I think, what time is it? 10 after? I think we got enough people here now. If people join later, that's okay. So we have a bunch of different presentations tonight. The whole idea is to give everybody a little more interactive opportunity. So Armando's going to be watching, and Felipe too, and Sheila. And so if people want to interrupt and ask questions or make comments, they can. We're going to be jumping from person to person because Sheila had the idea today of having, multidisciplinary cases, and that's what we've got. So different providers have the opportunity to be part of the whole thing. We're going to go through the next meetings we've attended, some articles, and then we'll get through the presentation. So we're going to go through the same stuff we've done always in the past. Our next meeting, Armando's the moderator, and when he's on, he'll talk about what he's going to be presenting. And then Luke is going to do the I Love What I Love program again. And then at the end, we're going to go through innovations and new stuff, and that'll be in March. Felipe's put in the section on chats, he's put in the link for the CE. So go ahead and put in, if you have any questions, go ahead and let us know through the chat. And then the CE link for the program is on that chat site. When you sign up, the RSVP, if you put in the address you want the invitation sent to, it'll automatically be sent to you. So when you register, it's automated as long as you put in your email that you want the link sent to. And that's a lot of people didn't put in the email, so they didn't get the invitation. I know a lot of people saw Tarnow's meeting. Does anybody want to talk about that? I don't know, is Keith on? I know he loves, he was one of Tarnow's, Tarnow was one of his mentors. But anyway, this meeting was really about immediate implant placement, the protocols that are state of the art, and really comes down to if it's appropriate, if the patient has the appropriate biotype, taking out the tooth, putting in an immediate, and either doing an immediate provisional or an immediate custom abutment is the way to go. It was a really good program. If I don't know if you can get watch it after the fact or not, but it's pretty good. I heard this program, the Academy of Osseointegration, and they talked about a material that I thought was really interesting. I mean, a lot of you may already know about Pecton, but this is a material, a polymer that's stronger than PEEK, and you can press it, you can mill it, you can print it. And I think the big thing about it, besides being, it's got the same compression and dynamics as bone and dentin, and it's wettable. So you can bond to it with almost any of your bonding agents. So I called and I've got an email into this Bill Norris to see if he'll present to our group because it is amazing. They're making custom abutments out of it that are permanent. Okay. He is casting this stuff to, or pressing this stuff to titanium abutments and, you know, the long titanium cylinders and screwing these things in. He's mixing it with like a metal substructure and then putting it over that and then bonding to that. And the outcomes are amazing and it's compressible. So a lot of the concerns that you have, like weight and super rigidity of the ceramics, you don't have with this stuff. So I was really intrigued by it, and it's been used in medicine forever. They print skulls out of it. They use it all over the body, and it is microbially a lot nicer than the other materials we're using. So if this guy will do it, hopefully we're going to have him on our as one of our virtual meetings, because I thought it was fantastic. So I sent everybody 2 articles. I don't know about you, but I'm sick and tired of COVID.
Yeah.
I mean, it really is. But these 2 articles, this is a meta-analysis. It's the first one that I've seen that's significant. And basically what it shows is that this stuff, the reason it's spreading so fast is because you're highly infectious really quickly. And they're not sure about asymptomatic. There's not enough data on asymptomatics to recommend quarantines guidelines. But basically within 4 days, or 5 days, you're probably highly infectious. And the other thing about it is that after you've been infected for 9 days, you're probably not infectious anymore, but you're going to test positive. You might test positive for months. So once you've been infected, it doesn't do any good to test really anymore because you could be positive for months. So after 10 days, if you're not sick, you're considered non-infectious anymore. And really, once you get symptoms or you get test positive, you just got to quarantine for 10 days. And this is metadata. So this is the highest level that there is. The next one was really why this is a summary of why some people get sick and some people don't. And really it gets down to IgG responses. And there's those people that don't do well don't have a profound IgG response. Those people who have this FC receptor binding issue are the ones that die. And also they've recognized that there's some immunity in some people. They'll test positive, even though they have, for IgM or IgG, IgG, because they have this S2 domain that's already been affected by previous COVID infections, not COVID, the novel COVID, but the older ones that infect other people. And I think Armando's wife was one like this, but they tend to do well. So the bottom line is, if you get symptoms, you've got to hide for 10 days. We had somebody come in the other day who tested positive for IgM and IgG, and she'd been here before and didn't test positive for that. And she's older and like in her late 70s, and she's no symptoms at all. So I tested her for antigen and sent her home. So it's really, this is a wicked disease because you get sick so fast, or you get contagious so fast, and you may not show symptoms and then you spread it because it's really highly contagious. Nothing we don't know, but now the data is in and it says why.
So RW?
Yeah.
Am I muted? No. So
No.
the one of the studies or whatever I was reading, they compared all the people in the hospital between medium and severe illness, but they didn't include, of course, people that did not need to be hospitalized.
Right.
But in the IgG, what would be interesting is people who have a high IgG, production or whatever you want to call it, people who, you know, do show high levels of IgG, do they show natural, whatever, immunity, or they don't get sick, or do they turn out to be the people that are, you know,
They're the people that do well are the people that have a robust IgG response.
Right.
Okay, those are the ones that do well. The ones that don't and have these this FC and this FC deficit, receptor deficit,
Mhm.
they're the ones that die.
But how do you know who those people are
Well,
beforehand?
they can test for it. They can test this, but it's hard to test for. Okay, but now they know what to look for. They didn't know what to look for.
Right,
They're
right.
trying to figure that out.
And the other thing I saw was too that it affects the ACE2. And
Yes.
I'm just curious, for people that take ACE inhibitors, blood pressure medications, does that affect their
Well, there's actually
response and
there's
immunity?
an active study on that very question right now.
Yeah.
I saw that they were doing a blinded study on giving patient ACE inhibitors. So
Yeah.
Yep.
Just curious, because
No, it's I think it's real interesting. So I think Sheila, you're up now. I'm going to stop sharing. If you want to share your case first.
Okay.
You want to go ahead?
Yes, I'm just trying to remember what Felipe told me.
You go to the bottom of the screen, it says share screen.
Okay, and then
Click on that. And then you go, and then you pick the screen you want and click share.
Do you see it?
Nope.
Oh, not yet. Okay,
There you go. You got it. Good job.
great.
So this was Sheila's idea. So I'll let her, this is what we're doing tonight. So I'll let her, she's the moderator about this.
So I'll give everybody a heads up. If you come up with a good idea, you might get asked to moderate a meeting. So for those of you who don't know me, I'm Sheila Samaddar. I'm a GP and I practice near the Washington Nationals baseball stadium. And this case that I'm presenting first is probably my all-time favorite case. I'm trying to move these people over here. Let's see. So this is a young lady who came to my office, and her chief complaint was, I want to fix my teeth. I look like a jack-o'-lantern. And she had some things going on as far as congenitally missing teeth. You'll see she's missing some upper anteriors. She's got a retained baby tooth, number C. She's got a pretty significant underbite. And one other thing that I'll point out that will come up later is she is morbidly obese, and she has been affected, you know, personality and self-esteem and whatnot because of the way her teeth looked and because of her body and because of just being a little bit of an introvert. And so she really wanted to make a change. She had limitations with this case. And before we go too far into the case, I will open it up and we can talk about different ways we could have approached this. She, you can see here, she's got some issues with the bite. She's move this thing out of the way. She's got an underbite in the front. She's got a severe underbite. The left is even worse. She's got the spacing up here with some flaring. She's got a little bit of a, not quite a U-shaped arch on the bottom, but she could use some expansion. And again, because of her weight, a lot of that can translate into the tongue. And so she probably was having breathing issues with not really having space for her tongue. And go to her pano and kind of see what she looked like here. She did end up having wisdom teeth taken out. So I will put it out there. She started with a consult with somebody in this group for surgery who isn't in the group anymore. And she expressed to this doctor that she absolutely did not want to have orthognathic surgery. So I would love to hear thoughts on what other people would have done. And then I'll go and I'll show you what we ended up doing. Anybody?
I'd like to hear from the orthodontist. What do you think you can do with this patient?
Well, you're not going to get any positive buccal overjet, I don't think. If there's, was she opposed to doing any type of surgically assisted expansion?
She did not want to do surgery at all.
I wonder if,
Okay.
if, you know, here's somebody who's morbidly obese, who's got sleep apnea. You know, did she get a sleep study?
Well, I'm just speculating. I'm not saying that she had any sort of airway issues, but I would suspect that that was contributory.
But
Because
did anybody write her a prescription to get a polysomnogram?
she didn't complain of symptoms. I'm just saying based on tongue size and arch size and that I suspect that it could have been, but she didn't screen positively for needing a referral. So she had other things that were more pressing. The other thing I want to throw out there is that financially, she didn't have a lot to work with. She did not have familial support. When I first met her, she was under the age of 30. So she had a lot of limitations in that regard as well.
So one of
Can I see-
one of the things that goes along with sleep apnea, if they have medical insurance, it's almost everything in their treatment is covered. So a lot of times with patients who don't have a lot of money and they are considering treatment, I'll go ahead and I'll send them a note to their physician, and even if they're in an HMO, and get a polysomnogram, because then you can justify doing a lot of things for them. A lot of times people say, I don't want surgery because they don't want to pay for it. And if it's paid for, they might do it. It's just
Yeah.
a note for, you know, it's not like dental insurance where you don't get it. In medical insurance, they pay for the sleep.
RW. So you're saying that they're going to pay for surgery as opposed to a sleep apneic appliance?
I didn't say that.
Okay, so I'm sorry. So when you say you're saying they might just pay for a corrective measure for the sleep apnea, but not
Yeah,
necessarily.
they might pay for an
Example.
appliance.
They
Okay.
what?
They might pay for an appliance. They might pay for CPAP. They might pay for surgery, but they'll have you know, depending on how restricted the plan is, they're going to make the patient get CPAP and appliance before they'll even think about surgery. That's
Okay.
normally the way it goes. So
Got it,
don't,
thanks.
you know, it's a good idea for you if you want to do sleep appliances to send them for a polysomnogram.
But
Right,
they
but-
will pay for the polysonogram.
Yeah, they'll pay for all the conservative
Yeah, the
measures.
test,
And then if people fail those, then they'll pay for surgery. They won't pay for surgery until they've failed the conservative approach.
of course.
But if they're paying for surgery, have you found them paying for any of the dental work associated after surgery or no?
Well, the dental work would come before the surgery. Like if you were going to do this case, I mean, I would assume that anybody that's going to do this case surgically, they're going to level and align the arches and put the
Sure.
implants in, and then they're going to do surgery. So that stuff would be done ahead of time.
Okay.
Well, she
So
had-
if you can't
I'm
do the
not saying
surgery,
that's appropriate for her, but
so if you can't do the surgery, then ideally you'd like to correct all the cross bites, but you're probably not going to be able to, especially the posterior. I'd like to see some anterior correction of the cross bites, so you can give her some guidance, possibly. You can get some alveolar warping. You can get some expansion, but probably more in the bicuspid areas, and maybe flare the anteriors a little bit. Maybe you can bring the lower and anteriors back. I don't remember exactly how stiff those teeth were, but you can get some correction. I'd like to see guidance if possible. So sometimes you can do some interproximal reduction in the lower if they're flared forward, but if those lower incisors are already retroclined, then that sort of takes that out of the options. can go back and see the picture.
And the other thing you can do is you can do a lot more expansion, even if you're not going to do a surgically assisted palatal expansion. If you do a Wilcodonics or a DOO case or an AOO case, which can be done in the office, you're going to be able to expand more and move those teeth around faster.
Is she willing to do that? That's
I
more
don't know.
expense.
Yeah, it is more expensive.
And then
But
you got to
can
worry
move
about
the teeth farther.
Yeah, if you're not going to do that, then you might be limited, but you can get some expansion. Then the tissue biotype plays a part, whether she's thin or thick, and how far you can push things. Can I see how the clinical photos again? This is how the angulation of those upper teeth are.
Ooh, this is tough.
But she's got spaces in the lower.
Mhm.
Some of these patients have a functional shift. They bite down and they're actually not that far class 3. They come in and maybe they're sort of edge to edge and they have no way of biting other than to shift their mandible forward. I find that's a lot of times you can gain like 2 millimeters and you're not quite as bad. And if she's a little more edge to edge, she's got like a 2 millimeter CRCO shift, and then it's not unreasonable to move the upper anteriors forward a little bit and close the lower spaces, retract them. They aren't retroclined, so I'd say that would be my goal. You got to open up spaces for the lateral incisors too.
Well, good. Well, I'm going to agree with both Dr. Emery and Dr. Shefferman. I wanted to see how we could do with expansion because, again, she did not want to have jaw surgery to correct this. And she knew that there would be limitations with doing ortho, and especially doing it with me versus going to an orthodontist. And we were both kind of hand in hand as far as, if you're going to be compliant, we're going to move slowly and it's going to take a little while. But she was on board knowing that our end result probably wasn't going to be perfect, but let's see how we can do. So I'm going to skip ahead past the pano, and this was her mid-treatment. And you can see that we had quite a nice improvement already. She's still a little bit in crossbite in the back, but compared to what she was, and this is not the final, the big thing is with that expansion, then we're concerned about tipping the molars outward, because then, as Dr. Shefferman will agree, they're not functional. And I certainly made my mistakes along the way with this case. I've never put buttons on a patient before and really don't want to have to again, but lesson learned. I've been doing Invisalign since it was offered to GPs. Originally, I took the very first course that GPs could take. So I've been doing Invisalign since 2002, and I really like it. Obviously, Invisalign has its drawbacks where traditional ortho would be better, but again, she did not want traditional ortho. She's very set in what she wanted and what she didn't want and what she would compromise and all that. So let me go. I don't know if I have these pictures here.
So Sheila, I have a question for you because I'm actually starting a case tomorrow that's a class 3.
Okay.
And using these buttons and elastics. And this will be my first button case. So what should I look out for?
Honestly,
Got any advice?
The reason I wouldn't do anything with elastics for class 3s personally, because I don't know enough about it and it's not something that's within my comfort zone. I would send that to Dr. Shefferman.
You can always ask me. I'm happy to help.
Yeah.
Okay, Isabel, talk to Dr. Shefferman.
Yeah.
I'm gonna be very transparent because again, I've done a lot of great cases, but this one, I developed a posterior open bite, and so I had to pull the teeth together, which is why I did the buttons and the elastics.
That's very common to develop a posterior open bite with Invisalign. I'd say probably a third of our patients, when we finish treatment, they feel like they're hitting harder on the bicuspids or cuspids, and so that's not unusual at all. Usually it'll settle down once they're only wearing retainers at night, but sometimes we have to cut off the distal, like cut off the molar area and let them settle in. And once in a while, we have to put buttons on. Putting buttons on, you just have to be careful that you have them wear the appliance when they're wearing the buttons. Otherwise, the teeth can move lingual on you because you're pulling from, you're not pulling from the center of the tooth. But I think this is a great case. And it might sound weird, an orthodontist saying it's okay to have a posterior crossbite, but as long as they're an occlusion and you have guidance. Posterior crossbites aren't good if you're going to have posterior interferences, but if you got cuspid guidance and anterior guidance, I don't see a problem with it, especially in adults.
I think my expectations for what I want to see with ortho might be a little bit beyond what Invisalign can typically give me. So I think that's a personal thing I have to get over. But I agree. If they're comfortable and they've got a home, then that's one thing. But sometimes there's no amount of expansion or magic is going to get them to what we would consider an ideal bite with ortho, especially with adults. I always tell every adult that I do that adult orthodontics is a series of compromises, and whether it's midline or whether it's the bite or whatnot, that it's not going to be perfect, but it's going to be better than what you have. So I'm going to skip.
I agree that the ideal in adults isn't necessarily what ideal is in kids. The ideal is a stable occlusion, nice aesthetics, and no interferences.
Absolutely. So I'm going to skip ahead. So she went on to a second oral surgeon, had the implants placed, and here she is holding before we put the restorations in. And so you can see she does have a little bit of a better bite. She's still a little bit of a cross bite here, but again, not perfect, but I'm pretty happy with the fact that she's hitting a little bit more solidly than she was. Also interiorly, that was a little bit hard for us to jump that underbite, but we got it. And we knew that we wanted to restore, but also with the amount of size discrepancy with the upper and lower arches, we would have had to cut down a lot of tooth structure to get where we wanted to aesthetically. So that was another reason that we did the ortho. Jumping ahead, you can see here where she started. And this is actually in Invisalign retainers with temps in her missing edentulous areas. Again, this is where she started, and this is what she looked like.
Wow.
And then after we restored, here's what she looks like. So again, not perfect, but boy, this could change somebody's life, right?
She should be thrilled.
Oh, she's ecstatic. She's ecstatic. Here's the before and after that she posted on Instagram.
Wow.
She even looks like she's lost weight.
She's lost 100 pounds.
I can tell.
Helped her self-esteem. It's helped her outlook in life. She's healthier. She's not taking medication. I mean, it's really nice. And she's, I'd say 33, 34 now. And she did this all on her own. She works for the city. So she had an okay insurance plan. So we worked with that. It took longer than it would have taken if she just had cash available.
How long did it take, Sheila, start to finish?
Oh my gosh. It didn't take this long. It didn't take 12 years. It took, I think it took about 6 years.
Okay.
It took a while. Because the other thing is she had to get the cash together too. So she waited on restoring her implants longer than she would have needed to, just because she didn't have the cash. And I ended up helping her out anyway, because I was like, we got to get this case done. And I want to have some nice, pretty pictures to show.
So how long was she in temporaries?
She was in temporaries probably a year.
Okay. So you were able to gauge the temporaries and check the bite and make sure everything was.
So she was actually just wearing her Invisalign retainers with Luxatemp in the Pontics, so that she just held like that. We didn't do temporaries on the implants.
Okay. So she was got it. And like a Invisalign retainer with the Pontics.
Exactly.
Yeah. Okay. Nice case.
Thank you.
Yeah, Sheila, that's a really nice case. I mean, that's worthy of presenting at an orthodontic conference. I mean, that you did a great job.
Oh, I love you.
Very.
But I'll still send my kids to you.
It's life-changing too.
Yeah.
Wow.
That's what's really satisfying about it. And I really do love what I do. And It's fun. It's fun to go to work every day. I'm tired, but it's very fun. So
Very
that's
good.
my first case. Anybody else have any comments of things that might have done differently or something that I might have not looked?
So I do have one question, just curiosity. So how long have the final crowns and everything been in place?
Over a year, probably a year and a half at this point.
So maybe this goes to John Schefferman. Would it be advisable? Well, I guess the patient wasn't having any pain, but since you were talking about, possibly sleep apnea and with the bite, would you have considered putting her or leaving her in temps longer to just gauge, how she was doing in terms of, functioning on them and if there were any issues with her bite or breaking prior to just going to the finals? And I don't know.
I think from a non-restorative purpose point of view, I think, the Invisalign takes too long to get a good sense of where her bite is going to be through that process. I can't speak as to how long to keep the temps on though.
Okay, got it. And is she in any kind of a night appliance, Sheila?
She's wearing, so what I do with people that are going from night guards to Invisalign to retention, I keep them in Invisalign retention. I use the retainers that Invisalign puts out, the Vivera.
Mm-hmm.
And when they come in for their checks, if they look like they're doing a lot of wear, then I'll switch them to an upper guard and keep them in a lower retainer.
Yep.
But she's staying in upper and lower Vivera and she's doing fine. And
how often does she wear them? I just have found when I usually will go with the upper guard with the Vivera. Do you find that if they're wearing them nightly that they last a fair amount of time, that they're not chewing through them?
the Vivera.
Yeah.
So the crazy thing is that Invisalign used to say that you're getting 4 sets of retainers and they're going to last you 4 years, but
No.
kind of horseshit, pardon my.
No way.
So now they're saying that they're only warranting them for 3 months a set, which is crazy because for what they charge for them. So I tell my patients that this is what Invisalign says. This is what I say. I said, you can try to wear them for close to a year. You will notice that when you put in the next set of retainers that you're going to be snug because over time they loosen up, etc. But yeah.
Okay.
I still prefer them over bonded lingual arches for so many reasons.
Yeah, no, I've had the frustration. So I just go to the upper night guard like straight away. So,
well, I mean, I agree with you. I get it because everybody in this town is clenching and grinding.
especially now.
But I'm shocked that people that have really, really bad clenching and grinding problems that had been in the night guard, I would say 8.5 out of 10 people are doing fine with the upper and lower Vivera retention and don't.
You know what I find? I find that the patients who have upper night guards, the enamel wearing against the plastic wears the plastic out a lot faster than plastic against plastic.
Yeah.
And so I see the same thing. That if you have upper and lower Essex or even Viveras, they last a lot longer.
I use a lab called Anilin, and they do a FlexiGuard, and I find that I don't have that issue. I don't know if you've ever they recommend that they you use you heat it in water for like 30 seconds prior to placing it in the mouth, and it gives it some flex. So I just have found it's a little more biocompatible.
Yeah, we're using the Astron one from Glidewell. It's the same thing. It's actually BPA free as well.
Yeah, no, it's so I've used them both. I agree I like them a lot.
Yeah, and I'll credit you, Carrie, with that because I've been using Ann Allen for years, ever since you introduced me.
Oh, good.
I personally have purchased many a night guard for myself. So,
Yeah.
and they're super comfortable.
They are. They're really nice.
So is Angela next on your list, Sheila?
She can be. Let me
We can do it.
Okay, I gotta.
Wait, I have one question,
Okay.
Sheila.
Yes,
What material did you use to fabricate the crowns?
they are Emax.
Okay.
And I do most of my, almost 100% of my work in-house with Cerac. However, when I do interiors, I'll pay the big bucks and I'll send them out and have them really done nicely. So I really like Microdental for my interior restorations. They cost a shit ton of money, pardon my French, but their aesthetics are so good. And she's a little whiter than I probably would have made her, but she wanted that, and she's very happy with what she got. So
Nice job.
Thank
Super
you.
good. Love it.
Beautiful. Really nice.
thank
Amazing.
you. I just have to figure out how to get Felipe.
Angela, what you want to do is share your screen.
Okay.
Should be at the bottom. It says screen sharing. It's in green.
Is that good?
Yep.
All right, so here you go. This is another interesting case that Sheila and I worked together. And maybe Sheila, you want to, is this the pano,
Yes,
most recent pano?
this is the original pano that she had.
Oh, okay. So this is how these patient presented to Sheila, and lots of areas of decay, and really you can see that the bicuspid number 13 has a very large periapical area. There's decay on 15, 14. I think you extracted the wisdom teeth, or somebody did. By the time I saw her, she had no wisdom teeth.
I took care of that.
Yeah, I took care of that. So this is how she presented. And these are the images. Obviously, Sheila took all these pictures. So you want to talk a little bit about her occlusion and all that here, Sheila?
Sure. So my kids go to Catholic school and have from like day one, and all the nuns come over to me, and their chief complaint is not that they're in pain and not that they have these huge areas of decay and they're sensitive, but I don't like my smile, and I think that I'm going to hit my teeth if I, put a glass, and I'm just, and you look at these teeth and you're like, I can see why you're concerned. So I'm like the Invisalign queen. I ended up putting her in Invisalign, and she knew that she had a lot of work to be done. So Dr. Nagara kindly, since I donated my time and lab and all this kind of stuff for this nun, Dr. Nagara kindly offered to help with the endo as well. So this is how this young lady started out. She actually looks really young, but she's like 48, which is miraculous.
Wow.
Maybe it's a prayer to God. I don't know, but she looks fabulous. But you can really see, especially when you look at this side view, how far her teeth are just sticking out into the next zip code. And if you look at the bottom too, so much crowding. She's just super tight in there. And so, and then again here from the left-hand side, you can see. So we got her concurrently in Invisalign. And for those of you, I'm sure a lot of you are already using scanners. So when we went to start restoring teeth, we actually just copied the teeth with Cerax so that we did not have to rescan to do new aligners, so that she could come in mid-ortho, get work done, and then keep it going. So we're simultaneously moving her forward with her care.
So one of these amazing things is that all these teeth movements and all the amount of decay that she had in the posterior dentition, it was, to me, really amazing to see how she absolutely was asymptomatic pretty much with most of her teeth. She developed some sensitivity on tooth number 15, and so we end up having to do a root canal on that tooth, and you can see the large periapical area, the radiolucency associated with number 13. Sheila prepared all these teeth, removed all the decay, and put her on temporaries, and she had absolutely no pain, which was to me very amazing. There was pulp exposure on number 12, number 13, I believe nothing on 14, and then 15 also needed to have treatment done. So when I saw her, she came in, we first did tooth number 15, did the root canal on that. And mind you, she is on temporaries, and I am not even removing any of these temporaries. I'm just going through the temps and doing the treatment that needed to be done. And so her teeth have been moved a lot from those original images, and you're going to get to see where she is right now, which is how she arrived to see me. And she's had tooth number 12 is vital. And that one had a pulp exposure. I've been again treated her for these other 2 teeth and monitoring everything else. Tooth number 14 is vital too. And I said to Sheila, given that you have very minimal movement to do in comparison to what you have seen, you will see in a minute where she is. It just seemed that maybe we don't need to do endo in tooth number 12. The tooth remains vital. This is how she is. And I was afraid, my thought process was, if this was the beginning of the treatment and her teeth had not been moved and you had to do vital pulp exposure and then move these tooth significantly, I would be very worried that this would develop into a pulpitis and be perhaps a little more aggressive. But given that she has no pathology, the scan is all clean, and the tooth is vital and remains being vital, and she's absolutely asymptomatic, I said, let's not do endo in 12. And we treated 13 and we treated 15. So these are some of the views from the scan. You can see this is tooth number 12. It looks pretty clean. And again, as an endodontist, I said to Sheila, I only see the pulp caps that fail. I don't get to see the pulp caps that do not fail, because obviously they don't end up at the endodontist. So it was, to me, very interesting because, and it could be, I've treated teeth endodontically, they've had a pulp capping done, or there was an exposure 2 years ago and then they need endo. I figure we can always do that later on if we have to, but it just seemed that given that there was a healthy tissues periapically and the tooth is testing vital, and the fact that she really didn't have to do much major movements on this tooth, that perhaps it would be best to leave it alone at the moment. So this is where she is right now. And this is with the Queen Sheila doing her Invisalign. So, I mean, I was just amazed because this is how I saw her. And when Sheila gave me the pictures of the before, my jaw dropped. I couldn't believe that she had moved all these teeth with all these carious lesions. And this lady, she must pray a lot or drink a lot of holy water. I said, because she doesn't have very little to no pain. I couldn't believe it. So Sheila, you told me that you're still not finished.
We're not quite there. I still want to bring her front teeth in a little bit. She's still, when you look at her from the profile, it's a little bit hard to see from this film, but she's still sticking out a little bit facially. So I wanted to tuck her in just a little bit more, but she should be done probably by Easter, and then we can pray again. We can pray some more.
Yeah. So we're monitoring number 12 and see she's still with her temps and see what happens there. I can always jump in any moment if we have to. Ideally, we would like to do it before the restoration goes in there if we have to, but I suppose we're just pushing the envelope in every which way here with this lady.
I think it's fascinating because for me, I just assume that if there's a pulp exposure, you need to have endo. So I really appreciated your different take on the situation, because as we know, dentistry is different from day to day. And I just loved that you were not going to just jump in there and do a root canal on a tooth just because, and to take the conservative approach, which I think a lot of us aren't really counseled on. So I think it was really eye-opening for me.
How was this soft tissue managed throughout all this? Were you managing that?
She is on a 3-month recall.
Yeah.
So
Angela.
Yeah.
Hey, I'm just wanted to comment on something you said. It's quite interesting because I have a professor at school, Maryland, we all went, talked to me about pulp caps and things. And, I pretty much, Sheila can attest, pretty much use a dental dam on everything I do in my office, always have from dental school, even though people think they don't know. I'm a big dental dam fan. But if you do, if you have a carious pulpal exposure under dental dam isolation, and I stress carious pulpal exposure, I have found that percentage of teeth probably post 5 to 10 years is greater than 65% in my practice.
Wow.
I have x-rays going back as far as 24 years on an annual basis on a tooth number 2 with the direct pulpal exposure, with the composite restoration. Patient does not want to do a crown, has has a history of periodontal disease, bone loss, comes in yearly, not even more than that, and has had no pain. Now, I understand the converse can happen, that the day they leave your office, they could be writhing in pain. So I let them know that. But I'm a big proponent of going that route first. And if I am going to wind up doing a larger restoration, i.e. a crown, I'll always have an attempt for at least 3 months, and letting them know what the risk is. But I always feel like, a lot of endodontists will cringe if I do that, but I have certain, parameters that I follow that if it meets that, then I will do that. And it's been helpful, even if it delays it.
I think it's a great approach. I have no objection to it, honestly. Vital teeth will endure a lot more dental treatment in a lifetime than a non-vital tooth. That is a fact. And so sometimes you put some of these teeth through a lot of abuse and perio treatments and surgery or whatever it is that they need. And in the long haul, if you don't really need to do it, because again, as I said, I only get to see the ones that fail. And in some occasions, yes, I do get to have, I like to know historically what happens to a tooth as an endodontist. We are like a one tooth doctor, like they send us a case to do a root canal on a tooth and we don't really know what has happened in the mouth of the patient in general. And so I like to ask for historical pictures and historical, the dental part. And why do they have a crown? And if I can, I will ask them, go and look at the record. Was there a crack here before? And then they go, oh yeah, there was deep decay. There was a pulp exposure, and I did a pulp cap. And that's the only time when I get, because now there's a crown and I can't see it. But I am sure that there is a lot of pulp cap teeth walking around. And again, I do think that you really nailed it in the head. If it's done under great isolation and it is all clean, they probably are walking around just fine.
Yeah, it's amazing. This, and even very, very deep filling. So I agree. So thank you.
Sure.
I'm just curious, what does the literature say, Angela?
About what?
About vital teeth and pulp exposures and
exactly exactly really what we are talking about. If you have a pulp exposure, it's really, if it's a vital pulp exposure or carious pulp exposure, they just clean it up and you do what you need to do and seal it and put a composite over it. But these things,
asymptomatic teeth as well.
Correct. Asymptomatic teeth.
Correct.
And that's, I wanted to say that a lot of the times, and I am not a restorative dentist, I don't pretend to be one, so please take this the way, in a good way. But I do think that probably placing composites is a multi-step procedure, and it takes several things to do, and the etching and the bonding and each one. And the honest truth is that I think some people probably cut corners into these things, and so the result is not going to be the same. But I think if it's done properly, you probably will have a better success rate, don't you think, Carrie?
I do. And the other thing that I find, and I don't know with the other people, but sometimes you do a very deep restoration, everything looks great, it's isolated, you etch, and then you get like the exposure to the pulp, and you see this tiny little bit of blood, and you feel like you spent this time prepping, and the patient's asymptomatic, and it's isolated. And I feel terrible then saying, okay, we need to do a root canal. So that's again where we do this. And I'd say a greater than 0%, they are doing well. Now, I'm not saying in 15 years, but at least greater than 5 years, I found very, very good,
Yeah. I also have to say that with the now more popular use of silver diamide fluoride, I have had very in posterior teeth, very deep restorations with a near pulp exposure. And I have used, if it's like distal marginal, you know, in a distal box of a tooth number 15, I can put that SDF in there and just close the whole thing up. And I got patients walking around and they are just fine. They don't have a problem. I mean, don't you think, like, I don't know how popular it is, the SDF, but I use it a lot with children, and also have used it in adults when I have a situation in which I can mask.
I've not used that. As anyone else?
I've used it on, you know, you have patients who are bisphosphonates and or they've been radiated. And I think it's really important in those patients. It's a tool that'll help you not pull teeth that really don't need to be pulled.
It's amazing. And
and
well,
even
that's
though-
because you're an oral surgeon. And from an endodontic point of view, I will tell you that sometimes I end up not doing endo in these teeth because it's bactericidal, the silver, you know, and it turns the tooth dark. This is the downside. So you don't want to use it in cosmetic areas. But when I have a decay that is very deep and it goes into that distal marginal area, and it's just, you can't see it really. And if they're going to put a restoration there, once they put the restoration, it really covers the discolored area.
Yeah, no, we use the SDF as well, sorry. And I've used it on some of my patients that are, you know, in nursing homes. And I have to tell you, even their gums look healthy when they come back.
It's amazing what that thing does.
Yeah. So, no, we've gone through bottles of it. We use it.
And
It's a great product.
All you need is a drop, you know.
Yeah.
And I believe that I want to say there is a new SDF out there that doesn't stain.
That's true.
Yes. Okay. Thank you.
Yeah.
Yes. I think I heard that, and I have my full bottle because all you need is a drop with a micro brush, and the way you apply it, Carrie, is that you remove your decay and you remove it on the peripheral area. You want to leave that margin clean where you're going to etch and bond, and in the center where you would be getting the pulp exposure, you just spoon a little bit and basically don't have a pulp exposure, and you just take this micro brush and you brush it up like if you're cleaning a toilet bowl. Okay.
So you want to leave if there's a little stick and explore, you want to leave the tiny decay.
Yes.
On top of it. Okay.
And you'd rub these micro brush into that area, and with the oxygen, it turns into this dark gray color.
Okay.
And then what did you say, Louis?
It oxidizes.
Yes.
So do you know what that newer is there someone who might know what that newer material is, or could RW?
It's exactly the same thing, but it has an inhibitor for the oxidization. So it's long-term. So it's more.
Is it the same brand?
Well, there's several brands now, but yeah, they all have exactly the same formulation. So what they did, they inhibited the oxidization to be as quick. So what you can do by putting a restoration, it will still do the chemical work that it needs to do in the decay and everything, but it will not turn the tooth dark. And by you putting a composite or whatever on top, it will look significantly better than it did before.
Okay.
So they delayed the action with oxygen. That's all they did.
Well, that's wonderful.
So, yeah, it's an incredible product. And it's recommended for pediatric and geriatric dentistry.
Yeah.
Sheila, how long did it take you with Invisalign for this patient?
She's been in about 14 months.
Okay.
So with this kind of case where there's a considerable amount of movement, I obviously don't want to move her too quickly, or any patient quickly. With Invisalign, the baseline set is a quarter of a milligram, a quarter, it's been a long day. A quarter of a milligram of movement.
Okay.
Millimeter of movement per set of trays. So depending on if you're moving a set of trays a week or a set of trays every 2 weeks, or even some people go shorter, but I didn't want to move her too quickly. So I did keep her at a week tray change. So she was moving a millimeter a month with her teeth.
And did you use precision cuts at all with this case or no? No.
I did.
Okay. Thank you.
Mhm.
All right, so I think we can move on. If there's no other questions, I think we're all good.
Nice
Thank you,
case.
nice case.
Thank you.
So can everybody see the next screen?
You?
I could a minute ago.
Yes. Can you see it?
Well, it
Not
was
now.
there.
It was there and now it's gone.
But we have a nicer screen now, it's Angela.
Way better. So I don't know if Matt is available or not. I know he's on daddy duty.
Duty or duty?
Duty.
Both.
Is Matt there? Matt?
He's not Dr. Emery.
Okay. All right. So then I'll start. I know this is a lady. The reason that we have this case is it fits in with Dr. Tarnow's lecture. It's almost the exact thing he was talking about. And this is a 40-year-old female that came in and she doesn't like the way this implant looks. She's had it for a number of years. This is the result of the third attempt at placing this implant in another city. So this is implant number 3 in the same site. And it's mobile. So, you know, fortunately, she doesn't show when she smiles, but she still hates the way it looks. And she's, as you can imagine, she's distressed at dentistry because she started with one tooth and now in an implant, and she kept being told that it was going to work. And then now she's complaining about this, showing this to the root there and showing the root there. And so she wants to know her options. So this is the CBCT of the case. Does anybody want to comment? Make comments?
Oh,
John
nice placement.
Yeah, this is the third time.
I love the buccal bone there.
Mm-hmm. Well, this is what happens when you don't guide. So anyway, there is no buccal bone, but probably the biggest problem is when we look up here, these contacts,
Yep.
they're gone. So does anybody have any comments so far? No? So this is the PA. I think the PAs are great for looking at contacts. And then what we did was we measured how much was missing from the different contacts on the mesial and the distal. So, and then Scott, are you there? Pets? Is he here? I guess Scott's not here. Matt sent her to Scott, to John and myself, and they wanted to evaluate the 2 adjacent teeth and end up, that the fills weren't dense, they were short. I think important thing on number 9 is that the post is there. That's going to be a restorative challenge for Matt. And then the last person to get, or not the last, but really important here is John Shefferman. So John, do you want to chime in based on what you said?
Well, yeah, sort of along with you, the big problem is she's obviously going to lose this implant, and there's going to be some massive defects up there. And then our he only can fill so much bone because there's no interproximal bone on either side of that where that defect is. So so that's our big issue is we need to develop sort of bone on either side of that defect so RW can fill it in. And RW, you want to talk about sort of how he staged that? I mean, yeah. Well, here, let me continue, because we talked about, you know, in orthodontics, if you extrude a tooth and you've got a healthy attachment, the bone and tissue will come with it. And we do that a lot. This is a more extreme example, and in theory, well, actually, practically, we want to extrude number 5 and number 7 and bring bone down. So then, sort of, RW has sort of a wall on either side to bridge some bone. But in doing that, we have to, as you extrude the tooth, she's got a nice, you know, she got a deep bite. Her teeth are already in occlusion, so that brings another issue in that as we extrude, we have to start grinding the crap out of these teeth to make room for them to come down. And that led from one thing to another. Number 7, if we extrude number 7, you know, we want to extrude it as much as possible. We'll bring bone on the distal of 7. As 7 comes down on the mesial of 7, we're going to end up with a whole bunch of extra tissue, but that should be our worst, you know, our worst problem. You can always cut that back. But then we had to talk about bringing down number 5, because if you just brought down 7, which we were talking about, then you have a mesial interproximal bone that you're developing, but not distal to the implant. So the mesial of number 5 still has the interproximal bone way up apically, and then RW is limited. Correct me if I'm wrong, RW, but you're limited in your ability to develop any type of a bridge of the bone in there. You'd have a really severe angle going apically from 7 towards 5. So then we want to go ahead and bring down 5. Well, that's a healthy tooth. In order to do that, then we introduce the idea of having to do sort of preemptive endo, and then cut the crap out of the tooth as we bring it down. But then she could have sort of a win-win. You bring down a wall of bone distal to the implant, and then also bring tissue down with the tooth and the recession that she's worried about on that tooth. She can have a crown and have a better gingival architecture there. But RW, you want to talk about how we're going to stage this, because you can't do all the bone grafting at once.
So first off, does anybody want to count? This is the problem list. You know, she's missing soft tissue. She has no attached tissue. Her vestibule is gone. She's got recession on her adjacent teeth. She's lost her attachments. She's lost bone volume, and she has endodontic issues all around. This all started as trauma when she was young, but then she had iatrogenic dentistry. So I think I want to open it up now for people. And first off, what are her options? And then what shouldn't we do? And then if you were going to do an ideal case versus a cover-up case, how would you do it? Because this is really hard for Matt because he has to explain all this to this woman. And this is about as complex a case as you can get. You got ortho, you got perio, you got endo, you got everything staring you at the face, and she's young. So anybody want to make any comments? What are the 2 ways of treating this? First off, if you're going to put in, how many people here would take out that tooth, graft it, and not address the adjacent teeth as far as the attachment goes? Would anybody put in an implant? You know, obviously we can graft it up to here. You know, we know where we can graft to. We can graft to here and we can graft to there. So you're going to get this slope of bone. All right. But would you do that and then put in an implant? Anybody?
So I have a question, RW. So this is the 3rd implant that she has. Does that mean that in the before implants, nobody has done that? Nobody has taken out the implant and grafted and waited and then gone to put the other implant?
No, what they did was they took out the tooth and grafted it, and they put the implant in the wrong place and it failed. And then they took it out and grafted again, and they put it in, it failed, and then they put it in here. And
see.
now it's failing.
The same surgeon?
Yes, it was an all-in-one doc.
Okay.
Does
So-
anyone ever look at metabolic things like does vitamin D or cholesterol or, like that? Does she have any other implants that worked in her head, or is this her only implant?
Well, this is her only implant, but I think that, the images are staring you in the face.
Well, the
Even-
position's crap, right?
Would you take the implant out, graft it, and just leave it for a
And
while?
just leave it.
Well, leave it for a while. I mean, you can put something in there, an Essex with a missing tooth, a fake tooth if you want, and then putting it in the right position, I would imagine would be quite helpful.
Well, first off, if just imagine that you did an ideal bone graft without adjusting these attachments, where is it going to be? Where is that implant going to be? It's going to be too deep, isn't it?
Yeah.
So if
Sure.
you don't address these adjacent teeth, I personally think an implant's a bad treatment plan for this woman,
Agree.
because you're going to doom her to having deep implants on each side of this when these teeth fail. So when you have loss of attachment like this, if you're not going to fix the teeth, there's two ways of fixing them. You can orthodontically extrude them, which is what John was talking about, or you can extract them. And that's what we often do in these cases, is we'll just extract the damaged teeth, because then you can get a graft from the distal of number 5, which is normal, to the mesial of number 7, which is normal. And so you'll get a curve of a graft for those 2 points. It's going to be lower, and she's going to need pink porcelain, but you're going to get an implant that's high up here and an implant that's high up there.
You're saying you'd extract 2 teeth adjacent to the implant?
We're not going to propose that to her, but I can tell you that if she doesn't want to do ortho, I would never put an implant in that site again.
But if you grafted it, if you took it out and grafted it and did, say, a conventional 3 and a bridge, and if you need to do pink porcelain, because she said it's not an aesthetic zone.
Well, you're going exactly where what we offered her, Carrie. I think your logic is right on beam. The option we offered her was the surgical options was included ortho, to extrude these and bring the attachments back up, and then put in an implant here. And if any of these teeth look worse down the road, as she's going through the ortho, she might get an implant here and nothing here. But we're offering her just a bridge versus or. So this is the plans, the options that she was given, which was to extract with a bone graft and let her heal, and then a soft tissue graft, and then a bridge. That's one option, right? Which is exactly where you were going, I think, Carrie.
Mm-hmm.
And then the other option is to extract it with a graft, do a soft tissue graft, then do extrusion, then reevaluate what's going on with this tooth and this tooth. And if everything looks good and it looks restorable, place an implant in 6. And then at the same time, this tooth down the road is going to be problematic. This might be. And this is going to need endo as well if it's extruded. So I think the approach that we came up with was to do this incrementally and see how things look and what's going on. The endo is a big deal here. And the restorative is going to be a nightmare for Matt, because as John extrudes it, this gets smaller and smaller and the tissue piles up, and you're trying to extrude it and you're putting provisionals on. So there's going to be a lot of visits. This is exactly a case that Tarnow presented, if anybody saw it. And, she's got to be invested in doing that. And then the other way to do this, which we didn't present to her, was to extract this and extract that, and then put a 3-unit implant bridge here. That's a cheap, fast way of doing implants if you want to do implants. And you're going to have your implants where they belong at the right level instead of deep like here.
Does that make
RW,
sense?
wouldn't you still have an angular problem if you just extracted those two teeth because the massive depth of that implant, you have an angular defect going straight from well then 8 to the base of where 6 is?
Well, no, but here's the deal. You can go vertically, right? It's never going to be perfect, but you can never graft anything above an attachment. I can't tell you how many patients are referred to me with failed grafts. And I look, and there is no way you're ever going to get a curve from that attachment to this attachment that goes down about 1.5 millimeters. It's universal. So if you just take this out and graft it, that's where the bone's going to be. Now, if you take this tooth out and that tooth out, you're going to go from this attachment to this attachment. So you're going to go from here to back here, and it's going to go something like that. So you're going to bring this up, but where are you going to put your implant? If you put an implant here, it's going to be like right here. And if you put an implant over here, it's going to be like right here. So your implants are going to be an ideal position, and then you're going to have a Pontic with some pink porcelain on it.
Can you plump the Pontic area with more soft tissue?
Well, that was my guess is that she's going to go with this, which is to extract this and then graft it and then add tissue to do exactly what you said, Louis.
To me, that makes the absolute most sense of all of them.
Yeah. Especially, this is what happens, people have these bad dental experiences, and then it's so hard for them to believe in dentistry again.
Of course.
I always feel really bad for these cases, but it's doable. And I think if you I just wanted to hear everybody's comments, because this is the exact same kind of case that, this one of these cases that requires a lot of coordinated care.
My only question, you wrote, if I'm not mistaken, you said you were going to deal with in refill number 7, but then later, it's this possibility of extraction of number 7 or 8 discussed. So when would you make that decision so as you're not endodontically revising it and then shortly thereafter extracting it? Or
John, do you want to comment?
Yeah, I mean, I think that we were just going to start extruding it and see if the bone is holding up. And we have a lot of challenges as we extrude that. I have to start grinding through the cingulum to make room for it to come down. There's going to be less and less retention. So at some point in time, we also might lose the ability to really grab onto that tooth so well. We are treating the lower, so the deep bite is going to be corrected by intruding the lower anterior teeth with some interproximal reduction. So we will be gaining a little bit of interincisal space. But we were just going to be watching if it starts getting too mobile, if the bone's not coming down with it like we want it to. But I don't think we're going to know until if we go this direction. We wouldn't know until we're sort of halfway into it.
Right.
Do you know what kind of material they're going to use for temps?
Well, Matt isn't here, and so I can't comment.
So I think that's critical.
Mm-hmm.
What would you recommend, Louis?
Well, there's several products. I mean, the one you were just talking about is a really, really good idea. It's relatively expensive right now, but that would be an extremely long-lasting temporary that it could become permanent, actually.
What was that product?
Pecton.
Pecton, okay.
So what it is,
Pecton's really cool material, I think.
So you can keep it cemented semi-permanently. So if you choose to do all this and the patient says, I believe in you all again, maybe you can go to the next step and just remove the Pontic and do 3 individual crowns and put an implant. So that material gives you a lot of flexibility. Then I will definitely do something with the old fashioned, I'll do a gold coping with peak on top of it, personally. So it's expensive for the restorative dentist, but it gives you an extremely amount of tightness, marginal integrity, and retention. So I think temporization is critical.
It sounds though as though cost wasn't really an issue with this case with all these potential variables.
Well, cost is always an issue.
But I don't think cost is going to stop this lady from doing something. I think it's more emotional in the time. You know, you're talking a 2-year time frame to put in another implant. So,
And then time to develop the gum tissue and all that.
yeah, I don't, is
She's also-
Isabel,
she's-
is
she's
Isabel
also not
still
gonna
here?
go back- Huh?
Is Isabel still here?
I am.
Okay, cool. This is Isabel's case. This case is really neat because it's almost 10 years of follow-up, and it shows old implant dentistry that I did and more contemporary stuff. So you want to start, Isabel?
What do you want me to say?
Well, this is
so-
2011. This is
Right.
where we started.
So this patient, actually, the original problem was she fell on her face. Typical issue, I guess. And when she came in 3.5 weeks after the fall. Tooth was slightly mobile, both 8 and 9. You know, they weren't ready to, you know, she wasn't ready to go to see Emory yet. Anyway, we put her on a bite guard. Teeth didn't resolve, and number 8 ended up failing. You know, did the implant, you know, extraction, implant placement. I'm just going to breeze through this and then you go back for details if you want them. Implant placed and restored with a traditional cement retained, you know, custom abutment, cement retained crown. And then what, 5 years later, 9 failed?
So I'm going to just revisit.
Yeah, I don't have the dates in front of me. Sorry, I have too many screens going.
Yes, so this is 2011. And this is, I'm just showing this because this case got dynamically guided in 2011 with the predicate, the IGI system.
I was going to ask you that. Okay.
Yeah, and you can see I'm doing a system check in here. I'm touching the tooth here, and you can see the software, the difference. It's just amazing. And this is the target view back then. You had to look here first, then get your angle here, and look at your angle and that position at the same time as the depth was. And this is where we're at now. Okay. But that still was, you look at how thick the bone graft looks there, right? You can see that bone. And I think it's important that we look at our stuff long term. Okay. Now this is her in 2020. And 2009 is, or 2020, number 9 is fractured. And you can see we have a little recession here. We've lost the papilla.
Papilla.
Yeah. And I think if I'm going to be critical, it's flat and a little erythematous here. And I think that's typical of the way we were doing it in 2010, 2009. Unfortunately, I think a lot of people are still doing the same thing. And this is the way she presents now. But you can see that she didn't lose a lot of bones in 9 years.
Is it a 3i?
Yeah, it's a 3i. Looks pretty good.
Actually, it does.
Yeah, for a 3i.
I didn't say that. I didn't say anything.
So this is the treatment in 2011, which is a partial root extraction. Okay, so we left the buccal and she got an immediate implant. So instead of waiting, and you can't do this with everybody, but she got a single stage implant and we can look at the soft tissue, the difference. You want to go now, we waited 2 months.
And so so now we're on a Straumann implant. We switched modalities and I ordered this is not it's kind of their peak abutment, temporary abutment, but I wanted to make her a temporary and sculpt the tissue a little bit. And of course, because this is my first root shield case, freaked the hell out of me because this abutment comes basically as a single size and was huge. And well, you can see from the picture, the composite that it comes with was all the way down. And of course, Dr. Emery lovely placed it nice and deep into the bone and the sulcus. So I had to grind away composite for 20 minutes. But ended up making her temporary.
And it's screw
And-
retained. It looks beautiful.
Yeah, and so yeah, I did screw retain, and when I ended up taking the impression that day, and she wore the temporary, I think, for a month. And then yeah, this is a photo of when she came back, how the tissue looked.
And
yeah.
to comment, you know, here is, remember how thick that bone was? You know, she had a lot of bone on the buckle, 2011, and look how flat it looks.
Yeah. So there we did nothing special. I mean, that was a traditional lab designed abutment and crown. And well, not only did I not do any tissue development, but I didn't know anything about the design and everything that we do now. So.
Well, I think really more of the problem there wasn't so much the restorative, it's just the bone melts over time, you know, and it happens. And if you look at the literature, Boozer and his long-term studies on bone grafts and everything we do, it disappears over time. Boozer's stuff has got serial radiographs going back 10 years and using xenograft, and they all flatten out. But if you look at this, there's no loss of the buccal convexity. And I don't know any other way to do that.
That's because you have the root shield.
That's
Yeah,
a root shield.
there's a root shield there. Okay, now, and there's where, you know, I've got almost 5 years now and about 35 root shields that I've been following, and there are a lot of complications with them. They're hard to do.
Can't put any pressure on them.
What?
Cannot put any pressure on them.
Well, so what, yeah, that's totally true. But what I think people, and I think, you know, what's going to end up happening is that we're going to be doing these open, you know, making incisions along like this, not touching the papilla, and exposing it so you can see the margin and bringing the shields down to the level of the bone. And then you will be able to drive in your abutments the way you want. So
Yeah.
this is 2011, okay? And you can see where the bone is. The bone's still pretty high. You know, we went from bone up here to the bone down to the, you know, just down to that first thread. And that's just the 3I biology. It's treatment, it's platform switched. These seem to do better. Shut up, Lewis.
Sorry.
What are you laughing about?
He knows my opinion about that.
Yes, he's a strawman man. And anyway, you know, it'll be interesting to see the response over time. So you don't see the root shield because the root shield's down the level of the bone. In this, some of the earlier ones, you'll see the root shields up higher. And this is the, you know, again, you see the difference. And again, when you do the guided surgery, guess where the implants are? There's
Where they're supposed to be.
Where they're supposed to be, and they're not like too far to the mesial or distal. I mean,
Well, that's the reason why you can do a screw retained.
Yep.
But
And-
actually, you know what? I have to compliment RW. I would imagine the first one could have probably been screw retained as well.
Yeah. Well,
I don't
Now
know.
with 3I,
the first one was guided. It was just guided with the IGI. There was nothing wrong with IGI except for just harder than hell to use.
Yeah.
And it's interesting that we get to see a case, you know, that's 10, you know, 9 years old that was guided with navigation. And then this is the soft tissue over that time, you know, and you for sure can see the difference here versus here, but this is not 9 years later either.
why didn't you put some connective tissue under 8? Just temporary?
You mean now?
Yeah.
Well, we didn't touch, you know, you could do that, sneak it up through here.
Yeah, that's what I was thinking.
Yeah, you could do that. No, I wouldn't, you know, you couldn't fault someone for doing that.
It would have made it pretty, but it's still the same.
Yeah, I don't remember.
Nice result.
Yeah, but I agree with you. I didn't put any smile. Does she show her smile? I should have put smile.
No. She doesn't show the tissue.
So I think Armando, you're up. Are you on? Are you still on? Anybody else have any comments on this one?
I'm still on. I'm here. All right, let's see. Oh, there it is. I actually have a pretty, can you guys hear me?
Yes.
Great. I actually have a pretty similar case to what our W's case was earlier. I don't know if you're going to present that one, but it's a little more complex. I think it involves the entire smile, the entire anterior zone. But anyway, the patient's demographics or the information about this patient, the background info is she's a 25-year-old patient, no past medical history, no meds, no allergies. She had a congenitally missing number 7 and 10, and she had an implant placed in January 2015 in upstate New York. Actually, 2 implants were placed. There was also, I'll show you guys in a second. There was an implant placed on number 6, and it was cantilevered to number 7, and it was also an implant placed for number 10. She says that, her main concern is implant number 10. She's like, I know there's something wrong with this implant because ever since it was placed, I immediately started having gum recession and inflammation. I then moved to, I'm sorry for the typos there. She then moved to Chicago in 2018, and a dentist there removed some excess cement. They also tried to take off the crown of the implant, and they were not able to, she said. She says that, she doesn't have any pain. She just knows that the way the tooth looks and the way the gums look concerns her, and she wants to see if she needs to do something now in order to sort of save the teeth that are adjacent to, specifically tooth number 10, which is her main concern. The restorative doctor is Dr. Sean Alex, who's also in the Zoom call, and please feel free to chime in, Dr. Alex.
Yes.
So this is the patient on Smile. Again, implant number, air number 6 is, or site number 6 is an implant. Cantilever number 7, 8 is a natural tooth, 9 is a natural tooth with the root canal, and 10 is an implant. 11 is a
Natural tooth.
Natural tooth. This is sort of like the free gingival margins of this case, pretty irregular, with some recession throughout. And this is just a side view, so you guys can get a look of the recession on number 9, and some of the tissue around number 10 and 9. This is the PA that Dr. Alex provided when he referred the patient over to me. And you can see the implant angulation of number 10 is not ideal. It is definitely right up against tooth number 9. And you can see some radio opaque material there. Maybe that's that excess cement that she was talking about back in a couple of years ago. And you can also appreciate, obviously, the loss of attachment distal to number 9, the bone loss around the implant, and such. This is just to give you the full picture. This is the other implant that was placed in upstate New York, implant number 6, also a little bit close to number 5. And this is the restoration that they elected to use. And this is the panoramic X-ray that I took the day when I met her a couple of weeks ago. And this is the CVCT. So on this, you can see that implant number 10 has, no buccal bone or very minimal buccal bone there. Apically, but coronally, there's very little. There's also, the implants in close proximity to number 9. This is a wide, I feel like this is a wide implant for a lateral incisor. I would, maybe could have picked a smaller diameter implant and poor implant angulation I'm sure you guys can appreciate that. This is sort of another view of the angulation of number 9 and number 10 and how they sort of collide with each other. This is the status of number 9. You know, also very minimal, very thin buccal plate, endo-treated tooth.
So she got that tooth number 9 treated after the implant was placed. Ever since the implant was placed, she's having sensitivity on that tooth. Then 3 years later, they ended up just doing a root canal for her, which was the same restorative dentist who restored the implant on number 10, who left the cement underneath.
Gotcha. This is just, again, just to show you guys implant number 6 as well on the other side. And so we, you know, Dr. Alex and I wanted to present this case because, you know, we're sure this is, you know, this would be a good multidisciplinary kind of case, but we wanted to get you guys' opinion on as to, you know, how to approach this case the best way. I'm sure there's multiple ways to do this, but we want to see, you know, what you guys think. You know, I put up here the problem list, which, you know, I think are irregular gingival margins, recession of number 9, bone loss, number 10 implant, loss of attachment of number 9. The color matching is also not very good here at this point. And then, you know, so several things there. Does anybody have any input, comments, or anything about this case?
What does the patient want, Armando?
The patient, you know, when I spoke with the patient, you know, she says, you know, again, I know there's something wrong with this implant. I know that, you know, the teeth adjacent to it had given me problems in the past, talking about number 9. Like, do I need to do something, or, you know, is this, if I don't do anything, is it going to be, am I going to regret it later on? And I mean, that's where she's at. She's not in any discomfort. She doesn't like the way it looks.
Yeah.
But the main thing is like that fear of, like, you know, what's going to happen here with am I going to lose my front teeth kind of deal.
Yeah, also she's 25, so she's not really happy with her smile, and none of the restorative are matching. Then also number 9 is starting to discolor. So before I do a full treatment on her, I wanted Armando to take a look at number 10 and have a solution before we go forward with the restorative part.
Does it probe between 9 and 10?
It does. Yes.
How deep is it?
It's I probed 6 millimeters there.
So it's 6 millimeters below the tissue we can see.
Yeah.
So you're 3/4 of the way down 9. So eventually 9's going to fail for sure, and 10's going to fail. So if it's probing 6 millimeters below that, that's like that's a big, huge, that's just a giant problem. And removing 9, 10 is going to be bare. You'd never get 9 out unless it unscrewed, you know, reverse torque without destroying, I mean, number 10 out with destroying 9. So you're exactly like the last case that we talked about.
What if you extruded 9 before you contemplated doing anything with number 10 just to get some bone growth in there?
Well, I don't think you could extrude it without getting infection, without taking out, you got to take out 9 first and graft it.
10.
Yeah, 10. I keep saying 10, I'm sorry, 10.
You know, in that Tarnow lecture, he did a technique where he unscrewed the abutment and he put the healing cap in, and he let the tissue overgrow on top of the healing cap. I wonder if that would be useful, putting in temporary bridge while you're doing the removal and trying to get, you know, before you attempt to take it out, get the tissue to overgrow to create more. I don't know. Do you know what I'm talking about?
Yeah, I mean, well, you do that on natural teeth too. I'm trying to remember the name of the technique.
He had a name for it.
Yeah,
ablation or some, I can't remember the name of it.
well, we do that with teeth a lot. The big issue here is that you're not gonna be able to move 9 until you take, what do you call it, 10 out. And, you know, I don't know how deep this is. How deep is that?
No, but even if you put a temporary in first, you know, detach the abutment.
Yeah, but what I'm saying is, if you have to have enough thickness for the tissue to grow over, I'm wondering, can you blow this? Do you have another image, Armando? Yeah, blow that part out, blow the cross section.
I'm not sure if I can do that, but I mean, I can do.
Well, just maybe one of the PAs will show it.
This one? This one?
Yeah, I mean, look where your soft tissue margin is. It's like 1.5 millimeters below that soft tissue, right?
Yeah.
So it's but what are you gonna gain with that soft tissue? I'm just trying to figure that out in this case. Would that help?
Yeah. I mean, the other concern that I have about this case is, you know, the lack of buccal bone on number 10. So yeah, so, you know, part of the answer is like, okay, remove number 10, but then you get this massive buccal defect there. So would it be a better choice to do like a tunnel graft on the buccal of 10, you know, with xenograft and PRF, try to sort of build up a buccal bone there, then reverse torque this implant, hopefully reverse torque the implant, you know, do socket preservation here, maybe then what Dr. Schefferman is suggesting, extruding number 9 to gain some bone in that area, and then what? And then placing 9 and 10 implants?
Yeah, but look at number 11, where the bone's at.
What about it?
It's pretty low.
Yeah.
Do you have PAs?
I do.
What is the other PA is the other side?
Number 6, yeah.
Yeah. Well, so I just finished doing a case like you were just talking about. It was another failed case, and we did exactly. I was going to show it today, but we have so many cases. I didn't take the implant out. I took a cover screw off. I let it cover up. Then I did a tunnel graft with Xeno and let it sit for 4 months. And then I torqued it out and grafted it, and it really came out nice. So your suggestion is a really good one for 10. Yeah, you can do exactly what you said, as long as you don't get infection of that tunnel graft. So that would be the advantage of doing what you said, Sarah.
So I guess the other question is, what would be the not to do's here? Like the not to do would be to ignore what's going on with number 9 and just take out the implant, graft the site, and then try to place a new implant, correct?
Yes. It's just like the other one we talked about.
Because then really, like if we do that, this, you know, I'm afraid that defect is going to be, you know, that gingival defect is going to get worse by doing that.
It will.
Yeah.
Well, you said, RW, that that's if the tunnel graft doesn't get infected, but you had a 6 millimeter pocket there.
Yeah, that's right.
And I think, obviously, there's no bone between 9 and 10. Or, you know, there's very little bone there. But naturally, you'll look at, from an endo point of view, all the scans that I do from anterior teeth, natural teeth, and I think one of you showed it today, there's very little bone on the buccal, and that's just the nature of most of the anterior, or a lot of the, not most, but a lot of the anterior teeth. There's very little thin buccal, cortical bone there. And it's fine like that on natural teeth, but I suppose that it's not the case for when you have an implant, like for that to survive, you know what I mean? A very thin layer of bone. Can you grow bone? Can you have bone? I mean, I'm asking because I have no clue. Can you do a tunnel graft and expect that to, take over that implant?
So the answer is you can. You can do it, but because of that defect, you don't know whether it's going to get infected or not. I mean,
highly likely.
Well, I was going to dig out this other case, if I can find it, show you.
Yeah.
Example, but yeah, you can, if as long as you get primary closure over it, and that's where what Sarah said is a good idea, is take that off if it covers over.
That's a good idea, yes.
Yeah, I think it's a great idea.
Well, and in the interim, if you put a temporary bridge in there, you can get the aesthetics to look halfway decent so that everything looks uniform. And then while you're doing all these different things, she'll look better and kind of feel a little bit more confident. I don't know how you can extrude 9 though if you have it wrapped up in the temporary. You also have to think about, you're doing all these things, what is the person going to look like?
Yeah.
In the interim, you have to make them presentable. I don't know. I mean, now it's easier, I guess, because people sit at home and they wear masks, so that's in their favor. But
yeah,
I don't think anyone wants to walk around toothless. So to put her in a temporary from 6 to 11, you use that implant. Those crowns are going to be trash anyway because they're not going to match what the final restoration is going to be.
If you try to use Invisalign and extrude 9 and you do it that way for the contact.
Could do that.
Well, it seems like the consensus is to take that cap off, to see if it covers up, and then do what Armando said, a tunnel graft. If it doesn't get infected, let it heal, and then unscrew that implant. And then, because you can't trephine that thing out of there, because you're going to zip number 9, and then you won't be able to pull 10 up, extrude it. So there's a lot of ifs, just like there were on that other case.
Yeah.
It's a cool case. It's amazing how hard we make our dentistry.
It's amazing how people survive in spite of the things we do,
Yes, it is.
Well, thank you guys for the input. Dr. Alex and I really appreciate your input. Thank you.
Thank you.
Yeah, so.
Have you met Alex before? I hate to speak out of turn, but I don't know if I know you, Alex.
No, I don't think I've been on here often.
Nice to meet you.
I usually work later on most days, so I get to miss most of it. But I'm trying to work on meeting up with you guys more often.
Oh, nice to have you.
Yeah,
nice to meet you.
So I think Sheila's suggestion today was a great one, and we definitely did more interacting today than we did before. Our next meeting is January the 5th, and Armando is moderating, so he's probably going to reach out to people before then. But it's going to come up quick, so I hope everybody has a nice evening, and thank you for attending.
Thanks for listening.
Thank you.
Thank you. Have a good evening.
Bye, everybody.
Thank
Happy
you.
holidays.
Bye.
Yeah.
Bye.
Bye.